I'll do it.
Okay.
We'll also do it, so we're not allowed to use this, right?
Yeah, we're not gonna, I mean,
You should enjoy the gloving.
I probably, yeah, like, we'll let you put a glove on.
Just a gel.
It's kind of painful, so you don't have to, like, I would just like stick your finger in and then feel for the prostate, you'll feel it. Try not to break your hands. Okay. So go ahead and then just, yeah, just exactly like the pressure, and then it's gonna feel kind of like a ridge, and that's the prostate, and then you would do the 360 degrees, they kind of like,
Is this?
Don't do that. Sorry.
That would have
Good job.
Awesome.
There you go.
Here, if you want.
That's yours. It's another one.
Oh.
But we also heard a story about one of the fourth years in his rotation, and his advice was always wear gloves that fit because they could break while you're in there. That's not what you want. So that is an important part.
Question.
Yeah.
Are we looking for like out-pouching, or is in-pouching also an issue?
Yeah, definitely.
Okay. So I was like, I feel like in-pouch, okay.
Another thing too, and you can't do this with the prostate, but you can do it with like testicles or breasts, is everybody, like we're bilateral animals, so we have two. And so if something feels different right versus left, then that's an issue.
What's up?
So this isn't something nurses can do?
I think it is.
We don't check prostates, nurse practitioners do, but at the instant level, we do not because of the vagal response and being very careful. So what would you tell us about that? Being careful not to hit a vagal response or having patient bear down while your finger is in there.
Well, then, yeah, they could defecate.
Right. Well, not only that, they could pass out.
I don't know if they've ever mentioned.
Yeah, I don't think they've ever mentioned, like, I didn't know why.
That is not good.
Yeah.
And that's like important too to mention, to relax the anal sphincter, you kind of, when they're kind of like in this position, you kind of tell them to bear down. And that with a gloved finger and lube allows you to stick your finger in and then feel for the prostate, quickly do the 360-degree sweep and then pull your finger out. So again, it's something you don't want to like linger doing, like it's not fun for anybody, so you just want to kind of get in, get out, know what you're doing.
Nurses do
Yeah.
love to remove feces. So we do that quite often, especially in your elderly patients, but you have to be very careful when doing that.
So you're saying depending on where your finger is, you could actually hit
It could
the
do harm. Absolutely, it could do harm. Or you could even, and I know that they've been taught this so too, but that's why as healthcare professionals, when you are going in orifices, we make our nurses hold your fingers up like this. If you can see your fingernails, they're too long.
Yeah.
So if you guys were to do that, you need to make sure you don't have any fingernails, any loose skin. If you do, you don't want to be the person going into an orifice.
Oh, I have been that person before a CTEC lab that has had to cut their nails.
Pam brings in.
She brings in
clippers.
nail
Yep,
clippers and inspects her nails.
And if you're dealing with an elderly patient, that area gets very, very thin, and you can perforate very, very easily, so you have to be very careful.
Does anyone else have any more questions?
Can I try the?
Yes, please.
I don't know how many times you get the chance to do this. So go
Yeah,
for it.
hopefully not a lot.
As a nutritionist.
If you're doing it as a nutritionist, there will be.
I don't know what
So like that little knob.
Yeah, that's it. Yep, that's it. It's like not, I mean, we learned how to do the female and male exams in January, actually. It feels like forever ago. We came back from Christmas break and I just remember thinking, oh my God, this is not something I want to learn to do. And it's not as bad.
It's pretty.
So can you guys explain
I don't know if I would go that far, but.
I don't know, like, I feel like I'm helping people get to places they were never going to check, you know what I'm saying? So.
And so when you were talking about that, you talked about doing that in a female patient, but obviously you're not looking for the prostate.
Right.
Explain what you were doing, because I think there's some confusion.
You check for like anal fissures or anything like that.
Or a GI bleed, yeah.
Right.
So if a woman came in, even though obviously women don't have prostates, if they had a family member that had prostate cancer, do you guys do checks to look for other kinds of cancer more like early or something? I just didn't know.
Like an anal cancer or something.
Yeah.
I don't know if you would necessarily.
I think you would do it more for like if they had a history of colon cancer.
Okay.
As opposed to prostate cancer.
But again, like I said, my patient that was female that I did this on, she came into the ER because she was passing out, and the doctor suspected some sort of GI bleed, and so that's why, like, to check for a lower GI bleed, you can go in, and like we've been talking about, you'll get some like fecal matter on your glove, and then you put it on the test, and then you put a solution on the test, and then if it turns blue, that means that there is blood, and so that would be like a lower GI bleed. And then for an upper GI bleed, like sometimes they vomit blood, and so you would think that.
And the reason that that test is there also is because it can be microscopic. Like literally, you could not see the blood at all. Like all you'll see is fecal matter. But if you use the test, sometimes you're like, oh, I had no idea. So it's nice to have like that reassurance, or even just a confirmation. Okay, there's something that I couldn't even see with my own eyes.
If the patient has hemorrhoids, what are you told about to them? Or
Be
recommend
gentle.
exams?
Yeah.
One of my,
So would have to do with.
Yeah.
one of my sim patients, he had hemorrhoids, and he said, I am very sensitive down there, just be very careful.
Right.
And so I made sure that I used extra lube, and I told him exactly what I was doing, when I was doing it. I wanted him to let me know if he felt any pain whatsoever. That way, like, I can adjust or I can stop, because you don't want to hurt your patient.
Right.
And so, yeah.
And I think that's like the big thing, is, and I think this goes across like the board for all of our health professions, is the people that we're working with, we really need them to trust us. And so the more that we talk to them and explain to them what we're doing and make them feel comfortable, the more cooperative they're gonna be.
And so, go ahead.
So like, if you're doing the hemocult and there's like just blood on the outside, how do you know, like, if it tests positive, how do you know if it's on the outside or the inside or both?
You might do a colonoscopy.
You
just to go
wouldn't
in
know.
and see what's going on.
And sometimes there are prolapsed organs. Prolapse just meaning it has come out of where it's supposed to be. I have seen a prolapsed cervix, and when I say prolapse, you can imagine a vagina, but what was supposed to be inside was actually outside of where it was supposed to be. So
That's
you
the
gotta be
face that I
careful of
made
those
when I
type
learned
of
about it.
things. Yeah, I know you're like, wait, what? So like a prolapsed rectum, trying to do a rectal exam, and there's the bottom, but the rectum is actually outside of it. It just kind of falls, especially that happens in older age when the muscles are no longer holding up what they're supposed to. So some people, like the cervix that I had that came out, the doctor actually lubricated it, because once it's outside of that that area that's kind of moist in it, you have to put some, almost like you would put lotion on your skin, you have to lubricate that before you put it back up there. There's other ways that you can do that, but you kind of just place it back up there, you know, and you place the rectum back up there sometimes, and you just do the rest of what you're supposed to do. But those are more frightening for me sometimes, because I'm like, oh no, I want to put it back where it's supposed to be, you know, a little OCD in my head. It's like, no, go back up there. But, you know, it happens. It happens, because when you get older, your muscles are not doing what they used to do when you were like in your teenage years or something. So that's something to be careful of. I have seen skin tags. Sometimes those are, sometimes they're just not painful. Like one of my patients knew themselves very well. They obviously cannot see their anus, but they was like, I have some skin tags back there. They don't hurt. So he knew his body. And for me, if I didn't ask him that or we didn't talk about it, I'd be like, okay, wait, does this hurt? Are you going to be uncomfortable if I do this? But they were just little skin tags, and they were just kind of on the outside organs. And we just, we're going to go past that, and that's okay. And he was like, yeah, it's fine. It's no big deal. So just having those type of conversations with your patients, because they know themselves a lot better.
Communication is
Yeah.
key.
Yeah.
You talked about sexual assault and doing exams. Is that something that you're talking about now?
It's coming up,
Okay.
actually, next week, we're doing a domestic violence lab.
Okay.
And so there are specifically trained healthcare providers, nurse practitioners, I believe,
Yes, and nurses.
and nurses, and then PAs and physicians that work with victims of sexual assault, because it's very different. And again, like, you don't want to re-traumatize the person, because speculum exam for all the females in here that probably had one, not pleasant. So if you have gone through some sort of trauma, then it's even less.
You never force anybody's legs open. You never, and there's certain terminology from right now. We just say something along the lines of, please relax, let your knees fall into our hands. So you're using different words than open your legs or just sit back and hang out. We don't say things like, oh my gosh. We don't say anything. We just say it looks normal, or you just kind of don't do anything at all. So there's certain terms that we use or we're trained to use so you don't alarm the patient, but also you kind of make them as comfortable as possible. I think, yeah, that kind of hits what we're learning now, but obviously we're going to be learning more about that soon.
Don't say things like good, like one of my
Yeah.
friends, he's like, during his breast exam, was like, your breasts are good, I mean, they're normal. So it's like, there's key words,
Yeah.
just stay away.
Stay away from them.
Yeah.
That looks awesome in there. What?
Yeah, at our stage, like, it's very exciting to see the cervix, so they really don't get excited.
Like, oh my God, it's there.
It's there, it exists. So, especially for these types of exams, the more professional demeanor that you can provide the patient, I think it just provides comfort because again, it's an awkward situation. I won't lie, I don't like going to the doctor any more than any of you do probably, so.
And even with domestic violence situations, keeping your facial expressions under check. Like if someone says something that you cannot relate to because you didn't go through that type of trauma, you can't, oh my God, really? And then you write it down. It's not a poker face, but it's more of an understanding, okay, I understand you've been going through that. Because once you make a face like this, or, like, oh my God, they will shut down, they will not tell you anything after that, and then that becomes a problem for you doing your job.
I was just wondering if the social work students, if you've talked yet in class, sort of been in a placement where you talk about people who've not a sexual assault.
Not as it would pertain to like exams based upon that trauma. Like pretty much the only time that I've worked with it is like really far after the fact.
Okay.
Like something that's happened during childhood, and then like in the capacities that I've worked, like having sessions with a person, maybe as much as like 20 or 30 years later.
Yeah.
Like talking about some like emotional trauma that maybe they still hold on to because of that.
Okay.
But as far as like the medical side with like the initial no experience.
Okay.
I shadowed at the CAC last year with Children's Services, and that's the Child Advocacy Center, and I think they only get child sexual assault cases that come through, and that was a really crazy week. So what they do is we assign an advocate to the person, so someone to guide you through each of these things, your doctor appointment, talking to the police and things like that. But it's really just about listening and knowing how to talk to someone and how to listen to their trauma. And yeah, just like you were saying, don't act surprised. Just listen to them and let them have their feelings, no judgment. So just stuff like that.
Yeah. Anyone else want to try before we pack our things up?
I'll give it a try.
So come on down.
You guys chose a really good point to go to. You guys.
A large glove.
I know. I was like,
Thought
these are
about how
cute
that's
little
gonna work.
kids. Does anyone have the test?
Yes, they're over here.
Question you don't get to ask too often.
Have you heard that?
Yeah. Yeah.
We have to put, it goes in the other way so we don't damage any dangling parts.
they were, yeah, they're plastic. Sonia, can you,
SLPs can also be in here, if you guys mind being at the end.
Right. Oh, did Tyler bring our forms?
Tyler just went to get them.
Okay.
All right.
We need to do that same survey for the.
Yeah, but this time you'd be keeping this group in mind for it. And we can just look at the timestamp to know who you filled it out for. I didn't think of that.
Yeah, me neither. I was just thinking like, as a whole.
Yeah. But then it's like, okay, can I really do that every time?
Thank you for
I would ask.
I'm assuming that's not right here.